Hello.
Mirzaul sir,
Hello, are you hearing us?
can you hear us? Mirzaul sir?
Yes, are you hearing?
Yeah.
Are you hearing me?
Yes, we are hearing.
Hello. Welcome to all of you from National Institute of Cardiovascular Diseases. Here I am Professor Mir Jamaluddin, Director, National Institute of Cardiovascular Diseases. With me, renowned interventional cardiologist of the world, Dr. Ramesh is with me, and my registrar, Dr. Sakib Shahriar, and my team, cath lab technologists and nurses are present. We started the case as because we are waiting for another half an hour, and our case. Show them the case.
Yeah.
You do this one.
Yeah, let's start with the case and we'll meanwhile go ahead.
Sir, somebody
so
can tell the short history of this patient.
For 47 years, elderly man, a young man, having old MI anterior and left ventricular ejection fraction 45% with viable myocardium in the LAD territory, and it was found that left dominant system and out of left dominant LAD was totally occluded, and distal left circumflex, that is LPDA, is also significant lesion, and RCA is non-critical lesion. RCA is non-dominant vessel, and it was tried in another center with wire crossed, but they did not able to cross the balloon, and that is why we kept this for the conference. And here today we have taken a view and we found that antegrade flow is there, and with the help of microcatheter we crossed the lesion, and after crossing the lesion we tried to cross the intravascular ultrasound catheter, but intravascular ultrasound catheter did not cross. Then we pre-dilated the lesion with 1.010 balloon, and then we have done the IVAS, and let us see what IVAS tells us. Show them the IVAS. Fibrocalcific lesion.
So let me ask one question, Mirjal sir. It is balloon undilatable lesion or balloon uncrossable lesion?
Previously it was balloon uncrossable lesion.
Ramesh, what do you think actually? What is your strategy like that way to go for IVAS first, then you can make a plan?
That's exactly right. I think
That's right.
this is a balloon uncrossable lesion. Yeah, the pressure, we need to give something.
Not a
And so balloon uncrossable lesions, what are the attempts that they tried with the 1.5 balloon, whether there is angiographic calcification, then you can immediately attempt to do a rotor straight away. But on this angio, as you can see, there's not much of calcium that is visible. There's no tram track appearance of calcium on either side of the vessel. So we decided to actually see whether we are supporting the blood pressure, which is a little bit on the lower side right now. But we thought we could cross with the 1.5.
Dr. Ramesh, sir, would you please, is it possible to remove your mask? The sound, we cannot actually.
somebody change the mask. And probably yesterday from National Heart Foundation, we.
Now it's okay. Now it's okay.
Same problem.
Yeah, now it's okay. Yes, sir.
Yes,
Please,
so
please.
we uncrossable lesion with 1.5, because we didn't see any calcium, I didn't want to go straight away with the rotor. So we tried with a 1.0 balloon, and so 1.0 balloon at 12 atmospheres to 18 atmospheres, we pre-dilated the lesion, and then we were able to perform the IVAS, which showed actually fibrocalcific disease, and there's at least about a 3 millimeter vessel distally, I think, and proximally it is almost 4.5 vessel, So, okay, yeah.
Approximately 4.40.
Yeah.
So there is a gross mismatch between proximal and distal diameter, 4.4, 2.75.
Yes.
Right. And I don't think we need to understand, I mean, here obviously the lesion was so tight that minimal lumen area was not even measurable, like it's a 1.6 or something.
Yes.
But is that after pre-dilation with the 1O balloon.
What is
So
what is the lesion length?
Lesion length is about 35 millimeters we got, I think. 38 millimeters.
38 millimeter.
Yeah.
So the 3 and 4.5. Lesion
yes.
is 3 and proximal is 4.5. How will you accommodate it?
Yeah, that's what, 2.75 was the safest one distally, but I think we can even go maybe a 3O and undersize to 8 millimeters, 8 atmospheres. And then proximally, I would dilate a pot with the 4O balloon. So there's a diagonal lesion. How many of you will?
But the proximal die is 4.5, 4.4.
Right.
4.4.
So
Yeah.
you want to proximal port by 4?
We have to go with 4 or 4.5 depending on our IVUS pictures. Here it is 4.5.
So do you have any stent selection? So who can go 3 to 4.5?
I mean, I think either
Difficult to.
difficult to do that. Either Synergy and Onyx are the ones that come close to it.
Yes.
But obviously, there you might lose some radial strength when we go up that high.
But maybe the IBUS was, you see the artery was a kind of elliptical. I think you overmeasure if you go to the IBUS, you would see, I think it's more 4.1 than 4.4. If you look at I think you overmeasure that one. So probably it's 4.1.
Yes,
Yeah.
maybe it is 4 point, close to 4.
Yeah, I would do 4O and the NC and then probably do another IVUS to see if we need to do any further post-dilatations of the proximal branch.
So
How many of you protect the diagonal?
So we did not see the actual
Please show the
angiographic
angiogram.
view of diagonal.
Please show the angiogram.
So
Yes.
the
We are
some
seeing the IVUS only.
So angiographic view, please.
The femoral pulse is very strong. Very good, very strong. Is working? Talking?
talk with him, talk with him.
So I have one question regarding like the CTO, Dr. Guzman. Like this was CTO, so distal vessel is underfilling, and after sometimes that vessel may dilate. So it looks to be 3 millimeter now.
2.5 balloon. Yeah.
Does it accommodate 3.25 or 3.5?
That's the reason why you do the IBUS, but you are correct. Many of these vessels will
If
grow.
the vessel is in spasm, then IVUS will measure the spasm vessel only.
Coming back.
Yeah, so it is correct that you probably will under expand if you follow this. I think the 4.0 is before the diagonal and before the septal. I'm not quite sure that it is 4.0 there, down there, but go ahead.
Yes, sir.
Yes, we are going for further dilatation, pre-dilatation with 2.5 millimeter balloon, NC balloon, as because it is a fibrotic.
So, sir, what is your strategy to predilate? Is it 0.75:1 or 1:1 in such calcified lesion?
Preferably 1:1, but initially we have taken a bit lower 2.5 balloon, and vessel dia is 2.75.
So you are telling it is fibrotic lesion. So do you consider Wolverine balloon for this adequate preparation?
We see, first we see with the NC balloon the result.
This is
Sandeep, what is your comment?
My comment is actually the case shown by Dr. Guzman that the LAD looked so small and in 3 months' time it was a massive. So it's a good point made that these vessels are underfilled. So these cases we do with DCB and only treat the proximal end with the stent and then reassess them. They come back in a few months. It'll be a much bigger vessel, positively remodeled. So when we stent in this time, we undersize the stent.
Sure.
Yes.
Yes.
So there are two big diagonal. Do you want to put a wire in the proximal diagonal just before the?
Yes. How many of you want to protect the side branch with a wire or side branch with a gel balloon in this case? From the panel.
I think
Yes.
Imad is here. Imad knows very well about sideburns protection. As all of you
Yes.
know, in the morning he gave a wonderful talk. But what is my feelings? What is my experience? If it is more than suppose 73 millimeter like that or 2.5 and very good size vessel, I really want to protect it. Then I consider to the wiring.
Exactly.
Otherwise, I don't go for this. Even I don't go for the wiring. I don't bother about the wiring. I don't think about.
Yes, we do agree with you, though the vessel length is longer.
But dia is less than 2.
Yes.
So no
Not
need
more-
to. So it is
Imad-
supplying less than 10% of the
Imad?
mygodium.
Sivan, what is your opinion, please?
Regarding diagonal, do you
Diagonal.
like to protect it?
Because our Dr. Dattu is concerned about the diagonal, both
So
diagonal.
it looks like 2, but I think after 5 minutes it will become 2.5 or even 2.75.
Yeah.
Yes, for that reason, we are going to save the diagonal and we are going with another floppy wire to the diagonal. Run through floppy wire.
So what's their problem?
Their problem is, do you want to protect the diagonals? Because diagonals seems to be not too much pretty good caliber vessel, not too much important. But do you think we
No,
should protect this side branch?
I think it is, the lesion is distally to the diagonal. And I'll not protect. But anyway, putting a wire will not take that much time.
Okay, go to cranial.
Cranial, just one wire.
Actually, what Imad want to say, it is not actually bifurcation lesion.
Yeah, it's not. It's not. I mean, just because of the angle that is coming off. If you're going to cover that area with a stent, it's probably better to be safe than sorry. And that's the only reason we are just putting a wire and that's a run through.
And
With,
it should be covered.
yeah.
That
So-
vessel should be covered.
Dr. Mir Jamaluddin, you have
Yeah.
a drug-eluting balloons. Would you want to do a DEB here instead of but it's very fibrotic, you know? I don't think unless you do a cutting balloon.
No, if I also use DCB here, it will recoil
Yes.
and we will not get the effective result. And that is why I like to put a stand here.
You are
So shall
talking, you are talking about the LED lesion covering, yeah? Or
Yes.
diagonal?
LED.
Yeah.
I think with the, if we were using DCB here, the way I would do is I use a scoring balloon or even an NC balloon inflate for at least 30 seconds. That prevents the recoil. And scoring balloon will certainly help in preparing better. And then you reassess before you use DCB. If there is a lot of dissection with flow limitation or recoil, then stent.
For your kind information, de novo large vessel, though it is doing with DCB, but there is no randomized controlled trial for de novo large vessels for using DCB.
So, Dr. Guzman, so this patient, how do you like to treat regarding the diagonal and the main vessel lesion?
We are going with 3 into 38 synergy.
In my opinion, we have to open up the balloon with the lesion better, prepare the lesion better, and see the result. According to the result, I would have decided on, because you have available DCB, I would have probably go in that direction. If there is not appropriate response, I would have put a stent. I would have not treat the diagonal. I would have used I would have forget about the diagonal. If you want to put a wire, it's okay, but I would have not treat the diagonal. Homer?
Yeah, agreed. We are not treating the diagonal.
I fully agree with you. So let's do nice preparation of the lesion. If everything is good, then no dissection. We can try DCB definitely. And if not, we can do stenting, of course, and post-dilatation. And regarding diagonal, yes, I would just keep it open with wire.
Yes. So, majority consensus to keep the wire in the diagonal and treat the LED.
Yes, we have kept the wire in the another floppy wire in the diagonal, and we have taken synergy
That's good.
3 into 38.
That's good.
Check. Do you want to check?
Yeah.
Is there any lesion just proximal to the CTO segment just before diagonal?
Yes, we are also.
You are covering that segment also?
Looks good now. Maybe come
What
back.
size of this stent?
Approximately there is another part.
What else?
So
What
I
is-
like cover that plaque also.
Okay.
So what is the size of this stent and which type of
Three-
stent?
3 into 8,
38.
3 into 38.
38.
Okay.
I think it's all right. We shall go to the low pressure.
So distally, I think we are missing an area in distally. So as it is 3, we should cover the distal first, then we can put, if needed, a 3.5 or 4 millimeter stent proximally.
Agreed, but you see the previous view. Show them the previous view.
Yes, now, yes, at the level of the
After
distal diagonal, that is quite normal, yeah?
Just before.
Okay, one next.
So just, yes, that is a good landing zone distally, yeah?
Okay, then
That's it.
you fluoro save that. You
So
want to
I think we are missing distally.
begin right there, right there. Check.
Sorry, how was the predilatation balloon? How much the size predilatation?
338, and immediately we will inflate up to 7, 8 nominal, and then we shall go further with the post dilatation with higher size balloon sequentially.
So for predilatation, which size of balloon did you use?
It is 2.75 stand. So what I like, gradually I increase
Down.
first 3, then 3.5, then 4. Somebody starts
Take
with
it, 4.
higher size like 4, 3.5, but I personally prefer gradual increase. Otherwise, sometimes I felt a strut fracture or there may be perforation with all on a sudden given a larger size balloon.
Sir, stent size is 2.75 or 3?
3O.
3O, sorry, 3O, then we shall start with 3.5. What is the opinion of the house? Shall we go with 4 or
Yeah, 4 I think is okay.
we can
Yeah.
also go with 4?
And low pressure.
Pressure is all right.
Yeah, one.
Major Officer Dr. Noor Alam here. May
Yes.
I know the hemodynamics of this patient at this moment?
Heart rate is 72, blood pressure is 103/70, 102, and mean pressure is 74.
That's good.
Patient is comfortable, and we are going for post dilatation.
So how much pressure, how much inflation with the initial?
8 atmosphere. 8 atmosphere we have given.
8. So what is the nominal of that synergy?
11.
11. So now you are taking for post dilatation 4 millimeter balloon.
Yes, yes.
Right.
So but distally, do you think that post 4 millimeter it will accommodate, or you like to do the proximally first, then you will take a smaller balloon for the distal post dilatation?
Up
You're right. I think we can go just a
Up to this?
little bit in. Yeah.
Up to this we can
Right,
dilate
right.
it.
Yes.
4. That is why my strategy is to go with sequential, like 3.5 the entire body and the proximal part with higher.
10.
Deflect.
Yeah. Come back and next one will be false. So actually, we used to have, I used in on Dr. Gortigan's lab one time, the Indian stent, which is a tapered stent.
Yes.
That would be nice to
Yes,
have here,
yes,
but we
yes.
don't have that anymore, I think.
We have not brought, that is available in Bangladesh.
14.
Yeah, doctor.
Yesterday, some of our speakers showed that synergy proximally they have got
Yeah. Four connector.
a 4 connector. Yeah, distally there is 2. So
Yeah.
with 4 connector, it will expand better with good
Yeah, the
radial.
reason that they have 4 connectors is because longitudinal foreshortening used to happen with the 2
Oh,
connectors.
yes.
So to avoid that, that's a very nice stent boost or
Show me. You see
Sure.
by stent enhancement, proximal part of the stent.
Yes.
go 18. So this 4 connectors will prevent that longitudinal foreshortening and maintain also some radial strength.
Deflect.
Is this 3.5 balloon?
No, 4
Four.
millimeter.
Four.
Yeah,
Four.
4.
Distally we shall go
We'll
with
do
3.5.
IVUS now and then we'll see
And
if anything
Okay.
else needs to be done. Is that okay?
And you see, we have post dilated by keeping the side branch where as it is. Many a time we keep the side branch up to the complete post dilatation. In that case, what my practice, I
Stop the
a bit-
noradrenaline, please. And
no pressure is all right. Stop.
pressure too much.
On question for the beginners, usually we took upsize post dilation balloon. Say your stent is 3 and usually we took 3.5. Why you took 4? Is
Thank
there
you,
a
Dr.
rationale?
Nur Alam. As you know, we have not gone distally. Just proximal part we have inflated with 4 proximal dilatation, as well as you can tell in other words spot. And then we are seeing with IVAS. According to the result of the IVAS, we shall go with the further 3.5 balloon if necessary for the distal part.
You know, I think even though I'm from America, we still believe in cost effectiveness, and so I think it is easy to see how it is. You know, if it is need be, then we'll do that. One more dilatation.
Yes.
Yes, that is very much important, especially in our perspective.
Yes,
Cost
we have
is a
crossed-
big issue.
We have crossed the balloon. You see the IVAS, pullback IVAS.
Can you show the IVAS for them, please?
Are you seeing? Yes. It is a high definition IVAS,
That's
High
a
definition means 60 hertz.
small-
60 megahertz.
Yeah, diagonal came, and you can see that that bookmark, and
Yes.
I mean there's still some plaque there, but the
Lot
minimal
of black, yes.
yeah, stent
But
area looks
apposition
very
is good.
MSA good. In 12 o'clock position, there is plaque.
Yes.
Now,
Fluoro, sir? Oh,
So
yeah,
there
that's
is some, there is
yes,
some,
yes, there is some
Yes.
malopposition
yes.
malopposition.
in the 6 to 9, 11 o'clock position at the proximal part.
No distal edge dissection, no proximal edge dissection. I think I will give you a minimal stent area from the distal part. Yeah, you can.
Under, yes, we shall have to take 3.5, 3.5 for distal part and 4.5 for the proximal part. Here for the younger colleagues, if I went with this 4 to the distal, then there would be catastrophe.
So it is 2.4. So 80% expansion is there.
Yeah, so I think that's what the most, the two important things are minimal stent area, the stent expansion, and lastly, apposition. I think if you give me these three, that's the order that I give the importance. So minimal stent area more than 5 as shown by ultimate study, and stent expansion anything more than 65% is good, and malapposition, I think that's where we don't have any good data. Some people have said that 900 micron of stent under expansion, malapposition is important, and that we should do something about it. And if it is more than 180 degrees of stent malapposition, that also we should expand more. You know. So, but that's all some research data that came from Patrick Sarayas' group.
Can I withdraw the side bounce back?
Did we take a picture?
So you are allowing 900 micrometer malapposition?
Yes.
Okay, we're going to
Yes,
pull the, yes sir, I mean that's one of the research, as I said, that malapposition is anything more than 200 you have to pay attention to, and the run-through wire was a little bit stuck there, and but we were able to get it out. But anything more than 200 is considered as malapposition, but what exactly when we should do more work to make sure it is opposed well is the question that I think they looked at 900 microns of that's 0.9 millimeters, of course, you know. I think that's
But in OCT, we are allowing less than 300 micrometer.
In OCT.
Yeah.
Yes.
You can
remaining inside.
in a little bit, sir.
Pull back.
No, in a little bit. More distal, more distal. Right there. Yeah, go up and
So this is 3O balloon,
Yes, 3.5.
3.5. So distally you are going with 3.5. Yes.
Yes. This is the 3.5 balloon inflation.
10. We're going to 10.
Step deflect.
Okay. Okay, go up.
Okay.
Yeah, so the OCT data on the malposition and 300 also, we don't have outcomes on based on that. Yeah, 14. Right. We know we do more aggressive ballooning if it is more than 300, but what does it exactly mean, you know?
To give 3.5 is no
So
help.
this is NC balloon, yeah?
Yes.
So
Yeah.
NC balloon, this recommendation is 12 atmosphere is the nominal for NC. So if we go for 10, suppose here 2.7 millimeter balloon. So 10, is it adequate to expand the stent well?
It is 3.5 balloon.
3.5, yes.
Yes.
Yeah.
Wow.
What is your post-dilating pressure, sir?
12 atmosphere.
12.
14 and now we are going up to 18 and
18, 20.
Sir, our question for
Yeah.
learning of the beginners, should we always remove the side wire, side branch wire before post dilatation, or we can keep? In this case, you have removed already.
yeah,
So-
you can keep it if you want. I think we did the first post dilatation already.
Keeping the-
balloon, keeping the wire in, and then we removed it.
And
Could we have kept it? Yes, absolutely. I don't think that there's anything wrong. And it all depends upon how comfortable you are in case if that occludes to go back. You know.
Yes. And there was jailed area was very much short, few millimeter only.
even then, you have, whether you have noticed or not, side branch wire was almost stuck.
Looks good.
Guide was pulling back, and in that
Oh,
for the
yes.
younger colleagues, I pulling back the guide in the left hand and pulling back the wire by the right hand.
So that is important to prevent over engagement and dissection by the guide catheter.
Yes, Professor.
Just for curiosity, when you did the IBUS, your vessel was 2.4, 2.6. Why did you decide to do post-dilatation with a 3.5?
No, so it was 2.75, and on initially that's the stent that we would have chosen, but because of the disparity, we went with the 3.0. And can you show me the distal edge of the stent? Okay, can you measure that? That's the distal edge. Okay.
IVAS, we cannot see the IVAS.
Can you show that to them, please? And
Yes.
measure that so from EEL to EEL over there. Measure that EEL. No, don't move that one. Don't move that one. Yeah, book. That's good. EEL to EEL. Go a little bit higher.
Oh, 3.3.
EEL. Good. Yeah.
Ramesh,
So-
did you give nitrates? Because I agree with, it was 2.5, but now it's gone bigger. So probably even some nitrates or maybe flow has made it bigger.
If we gave some nitro and then we were
Yeah.
worried the blood pressure suddenly dropped, and but that is a faulty, I think, measurement of.
Measurement. But at the moment, blood pressure is all right, and that is why we can.
So you can see on the IVAS, Dr. Guzman, that it is measuring in one angle, I think 3.39. Yeah, and 3.17 in one,
Is
right?
it an N balloon?
Sir, have you checked the ACT? How is the ACT now?
Yes.
We'll give
for
one
FAT.
more right now, but it was more than 250.
So I think this is an important subject because you can either underexpand or you can overexpand and create problems. So I will give you two different measurements. And so why don't we clarify for everybody, when you use IBUS, you use a distal reference site that has less than 50% cross-sectional area stenosis and a proximal that has the same criteria. So what you guys are measuring? Are you measuring the lumen in that specific spot, or you are measuring the EEM in that specific spot? And when you are saying we have an 80%, 60%, or whatever percentage you are using the percentage on the EEM, or you're using the percentage in the lumen that you are measuring? Can we, so everybody has a fair understanding of what we are saying?
Right. So the Japanese looked at, I think we had a Japanese colleague over there, they can comment as well. They believe that you should measure from media to media, not actually lumen. Whereas, first of all, you need to go beyond the lesion into a normal segment. And in that normal segment, when you take an IVUS picture, you need to measure either lumen to lumen or media to media. I think the Japanese believe it somewhere should be between lumen to lumen or media to media. Americans believe that it should be from EEL to EEL. But when you do EEL to EEL, you are going to run into a risk of perforations if you are being very aggressive. So don't go very aggressive inflations of the stent right away. If you're at EEL, go in nominal or even slightly below nominal, and then you can post dilate with a stent. That is what at least I do in my practice. Louis, what do you do?
So I think this is an important question, because many times this patient has a positive remodeling. So when you go from EEM to EEM, you may be measuring an area of the artery that it has positive remodeling. So I try to use media to media as good as I can, or lumen. I try not to do EEM to EEM, because I think you are going to overdilate and you can produce problems in those patients. So, and I use the criteria either if the lumen, if the artery is completely clean, I go lumen to lumen, or media to media is more or less the same. But if there is a lot of plaque, I try to find what is the media point, but I try not to use EEM.
Yes.
I agree.
We do agree. We also
Better to be safe than sorry.
yes.
Yeah, I think media to media is the best way to do it. The
Yes.
only other problem with the EM to EM, not only perforation but hematoma. Hematoma, I've seen hematoma happening, and then that's like a toothpaste. You can't cover it. It just keeps going down.
Then the IVUS,
Okay, that's the IVUS now for final.
final IVUS for LED.
That's okay.
There is no.
There's still some plaque, and I don't think here you need to be aggressive to post dilate any further. I think in my practice, I'll finish it here. Stop.
Well expanded.
Yeah. Okay, I think everything looks so good so far, and this is the proximal segment where we went with the 4-5. Okay.
Yes, that's
I think very nice results. It's very good expansion.
yes.
Yeah. Okay, so I mean, I think we showed you a case which is very interesting in my opinion, that we were able to cross the lesion with a floppy wire and a microcatheter, and we exchanged that for a balloon. Initially, IVUS did not cross then, but we went with the 1.5 balloon, 1.0 balloon, and we were able to perform the IVUS after that. And now with the further pre-dilations, we were not very aggressive in pre-dilations, as you can see. We didn't use a Wolverine, we didn't use IVL because there was this fibrocalcitosis. Yeah. And then I think we were able to stent it and show that based on IVUS, how we were able to post-dilate as need be, so that we don't have to be really too aggressive in post-dilatations as well. And we also said that there was a disparity between the size of the vessel, and but were able to do that with the one stent. So we did take
And now we want to go to the left circumflex.
There's a left PDS.
This is a dominant vessel. Dominant vessel having disease in the left PDA. There is also bifurcation.
So it is close to 8. Mr. Jamal sir,
The run
Yes.
would you like to
Data,
take
more
a
data.
NGO view?
NGO view of LED.
Yes, yes. Just by IVAS, it is perfectly good.
Okay, can you switch to from IVAS to they're only seeing
I
IVAS?
want to change the curve.
Oh, you like to finish with IVAS only? Yeah, that is a good idea.
No, we already took a final picture.
We have taken a picture also.
No, so we did not see the final picture,
Yeah,
angiographic
so that-
final picture. Yeah, we
Yes,
did not
yes.
show. We did not see it.
Show them this view, show them. Please show them.
Excellent.
Sir, how is the radar function? Is it okay?
Yes, okay.
And how much contrast meter you have been used by this time?
Till now,
Digital,
60
yes,
60 ml.
60 ml.
Another
it
20,
was
30
yeah,
ml.
they're
40.
quite reasonable. So angiographically, the stents distally seems to be over dilated, but I think vessel is actually underfilled distally rather than over dilatation of the stent.
Yeah.
So now what is your plan? Go for the fix to the distal LCX?
Yes,
Okay.
LPDA.
LCX, this is LPDA.
Yes.
LPDA. Yeah.
So I think
You don't have any plan to do the right coronary? No,
Right is
Non-dominant.
non-dominant.
non-dominant. Yeah.
Another few minutes. So far, I think
Oh, it is.
so.
we have time.
Our primary target to treat the LED in live case. So I think the
LPDA is a
rest
big
of the
branch.
Sir, can you go for diet statting here?
LPDA
no.
is a good branch.
LPDA is always very much valuable in a case of
Dominant vessel.
non-dominant RCA.
Yes.
What is the wire?
That is the floppy wire. That is
Renato,
Renato.
Not.
I think. Check or
Check. Yes.
That's it. Okay.
we have four more minutes time. We have 4 minutes time. So I think it is easy to tackle it.
Okay, thank you, Professor Azam. We shall be able to complete by
So by
Do you
this
like
time,
to
I
do-
think simultaneously, sir, you can introduce your cath lab team as well, because from the very beginning, I think you may forget to introduce everyone. So far, I know you.
probably.
You know me and the Safi.
We know, but we love to listen from your side.
So that LED is a great learning, especially for the juniors and for us also, regarding the vessel preparation, pre-stent IVAS findings. Approximately it is 4 millimeter. Angiographically, actually difficult to understand that it is 4 millimeter, but it is really 4 millimeter proximally. So definitely without IVAS, we usually used to put 3.5, up to 3.5 post dilatation. So definitely that is not good for long term.
No.
Which one?
For LED, if we don't do the IVAS in such a case, I used to do with 3.5 millimeter post dilatation. So angiographically that will be look good, but definitively IVAS gives the better assumption that 4 millimeter is the perfect size.
Sorry. Yeah. Sorry. Yeah, you're right, Dr. Datta, that I think you need to be understanding that once you do so many IVASs, probably you'll be okay to oversize or accurately size the balloon.
Now open this and air free.
Yeah.
So you like to do the pre-dilatation, then stenting, yeah?
Yes.
Right.
Yes.
So you don't have to stay with us, but we will perform this obviously.
Another 4
Go-
minutes.
go ahead.
If you give us
Eight,
budget only 4
10,
minutes more, then we can show.
10. Wow.
Reflect.
So it is 2.5 or 2.75 milliballoon?
2.5. Okay, go. 10, 12, 14.
Yes. Yeah.
14.
Good.
Okay, good.
Okay.
Dr. Robesh, do you think, is there any DCP can be used here? What is your plan?
In the circumflex, yeah, that's not a
In this
bad
part,
idea.
because it's a diffuse disease, small vessel, distal part.
That's right. This is a
But
good.
it's a long lesion. I don't know whether 1 DCB will be enough, no? How many?
30,
But is
30.
a dominant vessel stentable?
Up to 30. Our DCB is up to 30.
Dr.
That's
Purdip,
all right,
Yes.
but
is a dominant
you know,
vessel and stentable. Why should you go for DCB?
Because
dominant
it is distal vessel diffuse disease
Even then,
for the season.
that's
It's
because
not
RC
so
is a
distal,
non-dominant
like, I mean,
vessel.
it's a 2.5 millimeters, you know? I think it's not that small.
what is the length?
That is 9, sir, 9.
15. 2, 5.
So 2.5, 15 millimeter stent you are like to put, yeah?
Right.
Yeah.
2, 5, 15. Bottom.
Okay, we have IVUS, we can do this IVUS also.
Do you want to see IVUS?
Yes,
we can
definitely,
see
that is
IVUS.
a great idea. That can change your strategy.
Yes. Then Professor M.J. Azam will allot another 2 minutes.
Okay.
Yes. Professor Ajam,
Yes.
another 2 minutes.
Yes, sure.
Because this is learning for the juniors, then the
Yeah,
HIVAS,
yeah.
whether it can change your strategy in relation to the angiographic
Sir,
findings.
but it doesn't require for IVUS in the distal segments, particularly your experienced team.
Right, right.
Yes,
Right,
yeah.
right. And it's also whether we
Here
can
is an
even-
important message from the house. Dr.
Yeah.
Sivan is recommended, if pre-deal is very perfectly done, no
Trust.
flow limitation, no dissection,
Yes.
so we should
Show them IVUS, show them IVUS.
we should stop here, right, Sivan? Yes.
That's the scenario of left LED. Now you see the LCX. This is pullback of the IVUS from LCX, distal LPDA.
So,
that-
I think if there's already an IVUS on the table from the LAD, we should use it. I think that's,
Almost
there's
three.
already an IVUS. It's,
Media to media almost 3 distal.
3 millimeters, yeah. Okay, that's enough, I think. And
Okay, okay.
because
okay.
of time,
Stop.
otherwise
so
I would-
we can review the IVAS.
Very good size vessel.
So there is a
Yes.
small dissection here, but that is not,
A small dissection due to the balloon, predilatation,
yes.
and it will be covered.
look at that. Would you leave that alone now, Dr. Azam? You're saying that we can leave
DCB.
that. No, not DCB. Even I think they were saying that we can leave that alone.
Never.
So is there any criteria for dissection, IVAS criteria for dissection to leave it alone?
Yes.
What do you think, Ramesh, actually, in that particular situation, whether you
Regarding
go for...
IVUS criteria,
Yeah.
it is told by Dr. Antonio Colombo
Okay.
that pressure wire, put the pressure wire. and see
No. IVAS criteria for dissection to leave it alone. Not
Yeah.
angiographic, not pressure wire.
On OCT we have, but not on IVUS. The OCT, again, I think 270-degree arc of
Yes.
calcium, the length of the dissection segment, I forgot, I think it is either 5 or 10 millimeter.
5 or 10 millimeter, yeah.
Small and not completely 270-degree or less. Arc of dissection, you can leave it alone.
Yes.
Well, but
Thank
actually
you,
it is focal stenosis, distal stenosis. I think that if you have a good result with balloon, only balloon can be left, and with 70-80% of probabilities to be a definitive result.
That's all right, Dr. Guzman. If it would be a
Dr.
dark
Shaiban.
balloon,
No,
Shiba-
Dr. Sivan.
if it is a DCB, then nothing goes. Then we can be happy. But it is a plain balloon. As we know, the restenosis rate of plain balloon angioplasty is approximately 50%. Why we should keep this in this way with a plain balloon in a case of left dominant vessel with PDA lesion having a small dissection?
There was an area in the IBUS that it looked like there was a very focal napkin ring that you pass. I do not know that was an area that you balloon and is still under expanded, or because the person that is measuring, he measures the good part, but there was an area that it was a napkin ring. Do you see that?
Yes, I agree.
There is a calcification in the nearly 270-degree. You seen it?
Right.
Yeah, I think there is a calcium that needs to be cracked either with a scoring balloon or maybe with a high pressure NC balloon,
Yeah.
and then recheck. And I think for the use of
Can you show the
DCB,
IVAS again? The calcified portion?
And other thing that is very much important, especially for junior, if you like to do the POBA or DCB, adequate period of time, you have to keep the balloon inflated at adequate pressure. Suppose 12 atmospheric pressure, you should keep the balloon inflated for at least 40 seconds or 60 seconds.
that's a good point because that stops the recoil with an empty balloon.
Okay.
Yes,
And,
nominal.
what about the type of balloon, NC balloon or drug coated balloon? If you use it, especially drug coated balloon, at least 60 seconds you should
45
inflate.
seconds at least.
And if you think this is a really tight, very critical lesion, if you use the NC balloon, definitely at least you should go for 30 seconds. But Japan study shows
Okay,
3 consecutive
we have
inflation
better.
get better result. So what do you think actually, Dr. Sandeep?
One of the tips I give when I use
Deployment
DCB,
has been done and pulling back a bit the stent balloon, we inflated further and let us see the result. Whenever the proximal vessel will accommodate, then it can be possible. For the younger colleagues, if there is a significant or if there is insignificant plaque also in the proximal part, don't do it. Then it may cause death.
So the arc of calcium, you're right that there was a almost 360-degree arc of calcium, and it is a shorter segment, not more than 5 millimeters in length, or thickness as well. So that's why we went ahead with just a direct stenting, and so we'll see how IVAS shows now without even post-dilatation. We just post-dilated with the stent balloon, and further decisions can be made even offline. Okay, we're just going to show you the final IVAS
All right,
picture.
all right, no problem.
Go ahead and show the IVAS, please.
Yes, we are going
them.
once again with IVAS.
Not you.
Yes, we are going
Who push your wires?
wire first. For the younger colleagues, how to introduce the IVAS to a long lesion or distal lesion?
expand it.
You will pull the wire, and push the catheter with the wire.
Under expanded in the calcified segment.
Show them.
Yeah, they're seeing IVAS now.
Not yet a stent has come. Distal to the,
Yeah, this is a standard segment.
this is a stent.
Here,
Yes.
Yeah, here, right there.
Yeah.
Yes. So I think a bit further treatment it needed.
Yes, we shall post dilate further. We have not yet post dilated.
Yeah,
So-
we just use stent balloon. Yeah.
We just
Yes.
use the stent balloon.
Okay, thank you very much. I think this is, we'll take one final angio to show you. And can you go back to angio, please, for them? For the
Dr. Omar,
screen?
you have a comment, please.
Yeah.
Dr. Omar.
Dr. Omar have one comment, right, Omar?
Yes.
Okay.
yes, I think predilatation wasn't that good as Louis mentioned. We had to be careful about that because sometimes if you have circular calcification, we cannot expand the stent.
3O NC balloon.
So this is very
we
important.
have the 3O.
Yes, very important. Pre-dilatation is very
Yeah.
much important.
In here, of course,
Fine.
they do their best, but I don't know if they can expand it or not. I don't know.
Dr. Omar, I did not understand what
No,
you
you're
are.
saying that we
So
should have
he's telling
Yeah.
that your pre-dilatation of the lesion was not so good.
Adequate. Yes. But as the balloon, 2.5 balloon, there was no dog boning, and that is why we thought that if we give the stent and post-dilate the stent, it will also cover.
where the calcium is.
But at the end of the day, the procedure was seems to be very good looking. So we hope it will work more in future. So we should wrap up within 30 seconds. So do you have any
last
comment?
question regarding the recommendation regarding antiplatelets therapy, particularly for these patients.
Right. Slide, no. Slide.
Diffuse disease, long segment, long stent.
Stent enhancement. Stent enhancement.
Yeah, DAPT for 1 year minimum is what is recommended unless the
Yeah,
patient has
that's
high bleeding risk. So whether ticagrelor plus the aspirin, 81 or 75 here, we'll continue for as long as we can.
Okay.
Okay.
Well-
So this is a stent boost. As you can see, it is not that under expanded, but we'll go up more using a 3O NC balloon right now. Go up to 12, please.
And there is also a carb.
Go 12. Okay.
Which size is it, Ramesh?
Okay.
309 NC balloon.
Nice.
Stent was also 3 or 2.75?
7.5.
So until and unless contraindication or risk of HBR, so DAPT should be continued at least 1 year.
1 year. Yes.
Yeah. 14.
Okay. 14. 3 balloon and 14 atmosphere.
And proximally we'll go to 18 or no, okay, that's good.
I want to stent enhancement. Stent enhancement, please.
So, sir, how much additional radiation
Time.
stent enhancement give?
12 times. One enhancement will give 12 times than usual fluoroscopy. Cine, usual cine.
18.
More, straightforward.
On 12
I-
times more.
You can
Fluoro or?
I think, Mir Jamal sir, if you change your views, so
Okay.
I think you will be more happy because sometimes changing dimension give you more comfort. So would you like to take any more view from the opposite view?
Yeah.
That can take. Always we should see in
Sometimes
tangential.
we love to see good things, not
Yeah.
bad things, you know. That's why I'm telling you,
That's
you
right.
can.
We can show you.
More time go in, sir.
We shall show you in yellow cranial view.
In a little bit.
Suppose if you want to avoid the LED lesion, sometimes we are preferred to allocranial lesion to see. If
Yes.
you not need to go for it, standing, okay, it's okay.
Another 30 minutes, Professor Azam. 30 seconds. 30 seconds.
Okay.
Just
But
two
Dr.
views.
Sivan
One-
demands, he want to see, he love to see the final stent boost.
Final stent boost.
Oh, I have
Already balloon is removed.
Okay, forget it. So you take the another view, the good scene.
Balloon is off.
balloon now is
Okay,
out.
you just take a good scene. Okay, fine.
I think it would be good to have IVUS rather than stent booth
So
because
because I don't have any time, you know.
no,
next-
we have time another minute. This is important. You know,
Another
I'd like to
minute?
see- Yes,
Again? What?
That's it.
No.
Got
I
it.
think it seems to be pretty good, right?
it angiographic it looks better, but how about IVUS?
Now, do you want to see IVAS?
Yes, please.
Omar is interested to see the IVAS.
So Ajam will lose another 60 seconds.
If Professor M.J. Azam can give us another 10 minutes, we can show.
No, 10 minutes, I think it will not
Yes,
need.
sir.
1 second coming.
That's broken.
I
So
think
it
not
is,
for another.
It is overdilated, I think.
Okay, actually
Angiographically, it
IVAS catheter is
overdilated.
broken, so I think we should,
Last view.
yes, we should not to move forward.
So allocranial you are taking.
Yes.
Yeah. LA cranial.
You wanted to see in another view, in another perpendicular view, you show it. All right, Professor, Dr. Sakib Shahriar, his hand is not strong.
I think he is hungry.
Catheter is not good.
He should take
engagement.
double egg so that he can get
Oh, that
some-
is excellent.
I am withdrawing my wire.
Angiographically, that is definitively excellent, and I think IVUS, if you do the IVUS, that will give.
I think
perfect
Omar, you
result
should be
also.
happy with at least angiographically. So I think we should conclude this session. So thank you very much. You should give a very big hand for Professor Mir Jamaluddin and Dr. Ramesh Dagabati for the wonderful and brilliant case. Thank you.
Thank you.
I think
Thank you. We are also grateful to the sky.
I must
I-
give a special thanks Professor Mir Jamal on behalf of NICVD because he is the director of International Cardiovascular Disease. All of you know, and Ramesh Dagabati is the international program chair of SKY committee, and me is the SKY Bangladesh course director, and on behalf of national all course director, national organizer. Very big congratulations. Thank you very much. Thank you very much.
Thank you. Thank you all.
Thank you. Very fantastic job.
We are taking over. Okay, right? Thank you.
We have taken, Professor M.J. Azam, we have taken very simple case and we have shown very simply.
Yeah.
Just 1 minute. We just take a photo from you. The
Oh, yeah, Dr. Ramesh,
Oh, okay.
come please.
Just 1 minute. Okay.
Yes.
Just 1 minute.
Oh,
Okay.
okay. We have
Okay. Okay. You just click in the screen. Okay. Fine. Thank you.
Yes.
Thank you.
Thank you. Thank you.
Thank you.
Dr.